Right. So let me just take this opportunity again to wish everyone a blessed 2022. Thank you so much for joining us in our first webinar of the year. Before we start, I'm going to ask the president of CRMA to give us a word. You're muted. Dr. Shirley Curtis, you're muted.
Thank you. Good afternoon, everyone. Good evening, depending on where you're from. All 253 of you that are on now. We have 900 registrants for this particular webinar tonight. So we welcome you into our first webinar series for 2022. We are already in February. The year is speeding past. We are almost into the third month, but this is our first webinar for the year. And it's obvious that everyone is ready and hungry because the minute the webinar went up, I don't know if it's the webinar. I don't know if it's the topic. I don't know if it's the presenter, but this webinar seems to have generated a lot of interest, and we are extremely pleased about that. So we welcome you to our first webinar. As was said before, the topic for today is cervical cancer, key strategies for reducing the burden of disease. And our presenter tonight will be introduced to some and presented to others because we had Dr. Hathaway last year, at the end of last year. So we thank you for coming on. But before we move on, we would like to say happy independence to all of those online from St. Lucia. So I know you must be in COVID. Why? Or the topic is very interesting that on Independence Night, you are here. We appreciate your attendance tonight. So happy Independence to St. Lucia. And then I want you to give me some thumbs up and hand clapping emoji for our newest PhD midwife in the Caribbean, Mrs. Cynthia Pitter from Jamaica. She defended her dissertation last week successfully. So let's give her some love. Don't unmute your mics, but just give her some thumbs up and hand clap because she did an awesome job. I was privileged to be able to sit in on that dissertation defense, and she did an awesome job. She did us all proud. So congratulations, Dr. Pitter. Yes, and let that be an inspiration to others, those who are working on theirs and those who are contemplating. Please join the ranks of the advanced, the midwife who is advancing in knowledge. So congratulations, Cynthia. And then I want to thank the many countries that are online, and I know I don't have them all as yet, but by the end of the night, I hope I would have them all listed. So we want to welcome Curacao, Trinidad, Antigua, the Bahamas, Jamaica, Dominica, British Virgin Islands, Grenada, Montserrat, the UK, St. Lucia, Guyana, Turks and Caicos Islands, Barbados, St. Kitts and Nevis, Belize, St. Vincent, and I have one here, Lemeclin. I'm not sure where that is, and I want that person to qualify that particular place for me. And also, I noticed from the pictures and the names that we must say welcome to the males in our midst. Thank you very much. And I'm seeing more males than we normally would. So thank you very much for joining in our presentation. Just to say that at the end of the presentation, we will be putting our Google form in the chat for persons to click on so that they can put their name, answer some questions in order to get your certificate. Now, if you do not fill out the Google form, we will assume that you are not interested in getting a certificate. That is the only way we can keep track of who is on the call tonight. As we said, we're expecting up to 900 persons. So in order for us to keep track and for you to get your certificate, you must fill out that Google form at the end. And we will not be putting it there until the end of the presentation. Okay, so you must stay on and you must fill out that form in order to get your certificate. And because of the volume of persons that will be on the call, you have to give us 4 weeks to get your certificate. Okay, so you won't be getting it right away. You have to give our administrative assistant time. Okay. We would also like to welcome the persons from MCGL, Momentum Country Global Leadership, who are the sponsors for this particular webinar. And you will be hearing from 2 of the persons and as well as their support person who will be assisting us with the delivery of some of the poll questions that you will be getting tonight. So we want you to know that you're not just to listen, but we expect your full participation in the polls that you will be getting tonight. I don't want to take up any more of the presenters' time. So we just want to say thank you for coming and welcome. Back to you, Sonia.
Thank you very much. And for those that are now coming in, welcome to our first webinar, Cervical Cancer, Key Strategies for Reducing the Burden of Disease. Our presenter this evening is Dr. Mark Hathaway. He is a medical doctor with a master's in public health. He is a board certified obstetrician and gynecologist who worked at Washington Hospital Center, obstetrician and gynecologist in the faculty from 1997 to 2013 in Washington, D.C. There, he developed and led the section of community outreach, the family planning section, the Ryan Residency Program, and the Family Planning Fellowship. He currently serves as a family planning and reproductive health senior technical advisor for CSP JPEGO, an international NGO that focuses on international maternal child health programs. Dr. Hathaway has served on several national level work groups and committees, including the Institute of Medicine Standing Committee on Family Planning and the National Contraceptive Metrics Work Group. He holds appointment at Johns Hopkins University, Department of Obstetrics and Gynecology, and George Washington University as an associate clinical professor of healthcare services. He also serves as the board of directors of the National Family Planning and Reproductive Health Association and the Association of Reproductive Health and the Association of Reproductive Health Professionals, and now with Population Connection. Dr. Hathaway is a dedicated advocate interested in advancing reproductive health policy, family planning strategies, and the development of sound public health policy. We will now hear from our presenter. Remember, any questions that you have, just wait till after the presentation. unless Dr. Hathaway invite you to ask a question. But your questions will be taken at the end of the presentation. So we hope you enjoy the presentation.
Yes, they can put their questions in the chat as the presentation is moving along.
Okay.
Yes, thank you very much, Ms. Watson-Miller. I think, however, that my colleague An is going to speak a little bit before I start. So I think this might be the time for her to, and maybe you don't have her bio, so maybe she can introduce herself.
Yes, Anne should be
Yeah,
speaking
hi.
now.
Yeah,
Yes.
sure. I'm happy to do so. Thank you, Mark, and thank you, Dr. Shirley and Ms. Watson Miller. So I think I was asked to sort of just briefly say hello from the Momentum Country and Global Leadership Program. As you know, we're a USAID funded project that's working globally to build capacity and advance the acceleration of reduction of maternal, newborn, and child mortality. We also aim to increase women and girls' well-being. And I am the family planning director where we're promoting enabling women and girls to decide whether and when and how many children to have. So I come here to you from the family planning team, but as you know, we have many of us working in collaboration with the Caribbean Regional Midwives Association, and we're delighted to be collaborating on this series of webinars with you. We understand that one of the themes was family planning, but also that CRMA did a survey and that there is huge interest in cervical cancer screening. So we want to give the people what the people want and talk about cervical cancer screening, but perhaps in the context of taking advantage of the opportunities that family planning visits offer to integrate services. So in preparing for this session, Dr. Mark Hathaway and I have advocated to take a broader view and talk about efforts in general of reducing the burden of cervical cancer globally. So some of what you might be hearing tonight and discussing with Dr. Hathaway may not be as directly linked to your clinical or teaching practice, but I'm hoping it will spark interest and raise your awareness of what WHO and other norm-setting bodies are encouraging in terms of public health systems to address cervical cancer. And then I also want to take advantage of the fact to say that while I work on family planning for the Momentum Country and Global Leadership Program, I also represent my organization, which is JPIGO. And JPIGO has a stated vision around cervical cancer, which says that we aim for a world where an integrated and coordinated response improves downstaging of cancer and ending of preventable deaths from women's cancers. And as you will hear tonight, downstaging means detecting that disease earlier and at a more curable stage through various clinical approaches and screening. So I think it's appropriate for JPIGO for us as MCGL to be talking about cervical cancer and advancing that larger vision, which I think is very aligned with what your aims as a midwifery association are. And I think tonight, Dr. Hathaway will be asking you to think about also the integration aspects of your care as clinicians. You are in a setting where some of you might be expected to screen for cervical cancer within the context of a family planning visit. And we want to sort of advocate for you to always keep the needs of your clients at the center of your care. We all agree, I am sure, that cervical cancer screening is life-saving, but perhaps a client who's just there to try and squeeze in that visit to refill her prescription for a hormonal contraceptive during her lunch break, she may have other priorities. She may be concerned in the immediate about preventing pregnancy and keeping her job and not being late after her lunch, and may prefer a separate visit for a pap smear or screening. So we want to just say that clients' wish should always be respected, and that pap smear should never be a condition for receiving family planning information or services. And then conversely, if your role as a midwife involves a lot of outreach to schools or communities, and you're promoting a human papillomavirus vaccination for adolescents, there may be another way to integrate your efforts, and you could reflect on whether there are opportunities within that practice or for that vaccination encounter with young girls and boys to speak to them privately and say that your door is always open should they want to discuss other concerns they have about their sexuality or about how to prevent pregnancy. So integration is a heavy topic. It's complex, and one size does not fit all. We heard that you in all your different countries and settings have different ways that you're approaching both family planning and cervical cancer screening, and what might work in one of your clinics may not work elsewhere. But I think what the message I want to give you tonight is to be thoughtful about how to integrate in a way that puts the needs of your clients first and respects their wishes. And with that, I turn it back over to Dr. Hathaway, or Mark, as I call him. Enjoy the evening.
Thank you very much, Ann. Thank you. Yeah, it's pretty darn rare when I hear my name, it's Dr. Mark, from anybody, but thank you. Thank you very much, Mrs. Curtis and Ms. Watson-Miller, for the beautiful introductions. And I'm just honored to be able to share and discuss a little bit with you about ways and strategies to reduce cervical cancer. And also on my greetings to St. Lucia and their Independence Day. I was thrilled to hear that this morning. When I looked on my little calendar, I noticed that it's St. Lucia's Independence Day. So thanks very much for all of you that are joining and not out partying. And as difficult as it is to try to make this interactive, we've interjected some polling questions and some questions throughout. And they're anonymous. So when you look at the questions, don't hesitate to answer something. It helps us think through, and I will try to make this as interactive as possible, but the polling questions are really about the only way we have to do that. I'm going to try now to share my screen, unless Eva, you have it up already somehow.
I do not, Mark. Go ahead.
Okay. Now I'm not sure can share my screen yet.
Yes, you should be able to. Okay, it's coming up now.
There we go. You seeing that?
Yes, we are.
Okay, great. Here's some background noise, but I'll.
Yeah, trying to find that source.
We are asking everyone, except for the presenter, to please mute your mic, please. Please remember to mute.
Great, thanks very much. So what you're seeing now is, for those of you that participated in the last little session that I did, we wanted to do a quick little refresher. And so if you can pull up the first questions, and this is kind of a refresher. And I know that some of you weren't on that last session where we talked about the mechanism of action and the medical eligibility criteria. So here's a few questions just to touch on some issues we mentioned in the last webinar. So the first one, you can go ahead and answer that.
A person saying the question.
I can see the question right now.
Mhm.
So just the
Okay,
first
so
one.
so you can just go ahead and answer the first question.
Not submitting.
Is it working?
It's not submitting.
All right.
Maybe you have to do all before it would.
Just
allow-
having some problems submitting.
Yeah. Maybe you need to answer all of the questions first
Oh,
and then.
Yeah,
submit.
unable to submit.
Yeah.
maybe we have to answer all of them. I heard someone say, I'll try that.
No,
No?
some persons are able to answer, so I don't understand why. We're getting some answers in. Okay. They're coming in now.
Yeah,
Great.
but some of us can't submit.
Yes.
Oh,
Submit in
there
the
was
chat.
a notification that says if you have an older version of Zoom,
Okay,
that you might not be able to
to submit. Okay.
participate in the polling. I did see that when we were actually doing it.
Okay.
Sorry.
Well, go with what you have.
Mhm. I have some que-
Can some of us put the answer in the chat? Since it's
Yes,
just
sure.
the question.
Mhm.
So everyone, for those that are unable to submit, you can put it in the chat.
And I'm not seeing the results, but I'm assuming someone will share that with me.
All right. For the first question, we still have persons answering. You could let me know when the time is up.
Can we tell the percentage of folks that have answered?
So far we have about 90%.
Great. Okay, that's all. So this, I'm hoping, I'm assuming that people can see this now.
Mhm.
Yeah.
So what I'm
So-
showing, so the answer, I can't see
The poll
the
has
poll results.
58% said when C, when fertilization, when sperm meets egg. 35% when implantation, 5% beta HCG, and what is that? 1% unsure.
Got it.
Mhm.
Great. So the answer is implantation. And, you know, this is, if you weren't on the last webinar, you may have missed this, but this is when the fertilized egg meets and hits the wall of the uterus, which that's what we define pregnancy. That's when pregnancy starts, because that's when we can measure something. A fertilized egg may never make it that far, it may die, it may be miscarried or pass out, whatever implanting. But the definition, because of the fact that that's what we measure, the definition of pregnancy is implantation. All of the contraceptive methods that we use in every country in the world pretty much are those methods that prevent the sperm and the egg from ever getting together. That's why they did not cause abortions. So I'm glad we reviewed this. And so the answer is implantation. All right, let's go to the next question, which was the effectiveness of hormonal implants and IUDs. It may have been on that last bunch of questions, but I think it was the second one.
Yes.
So we can answer that one now. And again, this is anonymous, so you don't feel bad if you don't know the answer.
And persons who can't submit, you can put your answers in the chat. But then, of course, you're not anonymous anymore, but
Right. Right.
but you can, if you want to participate, yes.
Mhm.
There's quite a number of C's in the
Great.
chat. C.
Yeah.
I'm guessing that most people are,
But we have 54% saying C. We have 29% at B, 11% at A, 6% unsure.
got it. The correct answer is C. And this is a brief little counseling tool that USAID put together several years ago with WHO, and basically points this top tier are the methods that are 99% effective or more. And they include all of the implants that are available in various countries. That includes Implanon NXT, Jadel, Levoplant, and then there's the copper IUD and the hormonal IUDs. And they are as effective, and in some cases more effective, than a female sterilization or vasectomy. So these methods, those that answer to the C, they're 99% effective or more, incredibly effective, which makes them some of the what people refer to as the top tier. Now, effectiveness is not the only thing that's important to women, but if that is something very important to women, then these are methods, also known as LARC methods, long-acting reversible contraceptive methods, are the most effective. All right, let's do a couple more questions. The next one is question number C7. It may have been, I forget where it was. It had to do with MEC.
Okay, we're going down to question 7.
And again, I know
Okay.
some of you weren't on this last webinar, so.
So 21% is saying medical eligibility criteria, not 21, sorry, 51 is saying medical eligibility criteria. 2% meconium, 28% main equivalent in contraceptives, and 20% unsure.
Great, great. So the correct answer, and I have to give credit, I guess, to those that put in meconium, because we do use that frequently, those of us that are midwives or obstetricians and deliver
Yes.
infants. So we do use that. But what this refers to is what's called the medical eligibility criteria. And it's a tool used, this is what the app looks like on a phone. And the tool is used to help reduce barriers and help women get contraceptive methods when they're with you. So you avoid, you can look up things like, if a woman has high blood pressure, could she use an IUD, or could she use hormonal IUD or hormonal contraceptive pills? So this tool, this is from the CDC. There's also one that's almost identical from the WHO. Fantastic tool to use if you're trying to figure out when women can use methods, or you're trying to reduce those barriers and obstacles for them. So here's an example of what it would look like on the medical eligibility criteria app. So a woman has non-migraines, or let's go to B, where she has migraines without aura. These methods are safer to use. Copper IUDs, implants, Depo-Provera, even combined hormonal contraceptives, what was considered category 2. So these are safe for her. If we were to plug in with aura, that's a different story. At any rate, that's what the medical eligibility criteria is all about. And it's incredibly simple, fantastic tool. If you haven't downloaded it yet, do so. It's free. And yeah, you'll be happy to have it. Okay. So I guess if there's any questions about contraceptive or family planning, anything of that nature, we can share those or save those towards the end, because the main topic that we're talking about tonight is global efforts to reduce cervical cancer burden. And it's one of the few cancers in the world in fact, I'm sorry, it's the only cancer in the world where we now know that we can eliminate it. We know its mechanism, we know what causes it, and we can eliminate it. It's one of the only cancers now that we have strategies to eliminate the burden of disease. So what I'm going to refer to, I've broken this session up into kind of two parts. And they kind of merge together, but they're pretty much two parts. And the first is we'll talk about the global trends of reducing cervical cancer as a large and major public health problem. We'll discuss some of the WHO's key strategies and key approaches. Some of those I'm guessing you're already using in some of your countries. And then we'll share ideas to support expansion of technology and prevention strategies. So this is a kind of a map of the world which shows where cervical cancer has the highest burden. And you'll notice that Africa and some parts of Asia, Southeast Asia have a high burden, and also in the Caribbean, some of those countries are noted here, Central America, some in South America. So this is a fairly older slide, a few years old now, from 2018, but it shows just the rates of cervical cancer in all age groups. And you'll see in the next few slides, the goal is to try to reduce that burden and even perhaps get it down to eliminate it. We expect the burden to go up by 2030, and then hopefully if strategies are effective, we'll start reducing cervical cancer deaths. Most of the cervical cancer cases now occur in lower or middle income countries where access is limited to vaccinations, limited to screening and treating mechanisms. And in combination, those two things can go a long way. We also know that the burden of disease is much greater on women who are HIV positive. And this just points that out a little bit more. In endemic populations, where there's 15 to 20% of HIV positive women, they have a higher rate of HPV persistent infections, and therefore there's an accelerated progression. Antiretroviral drugs do a lot towards reducing that slow progression. So, of course, if a woman is on an antiretroviral, her chances of getting cervical cancer are very, very low, but that's crucial. I'm going to back this up now, and can we bring up the first polling question from the cervical cancer group? Just the first one, if you could. Well, I guess they're all together. Well, oh no, this is from, yes, let's just answer the first one. If there's a way to separate these out, great, but let's just answer the first one.
A person saying the first question. Okay, we're getting some answers now.
Great.
A person saying the questions,
Some,
I'm not
some
seeing
are,
any
some are
responses.
saying they're not seeing the first question, but I think you had said that if you don't have the updated Zoom, you're
Right,
gonna have some challenges.
okay. The questions are coming in. They're just taking their time, but answering it. Yeah. It's slower.
Can you see the numbers of participants that are answering the questions or just percentage?
The number and the percentage.
I'm just kind of curious how many
So
aren't
some
able.
persons are answering it in the chat, and
Mhm.
because they are not seeing it, or they can't access it. But we have about about 55 persons have answered already, but we have 510 persons on this call, so we're expecting to see more answers than that. Okay, they're coming.
In the
They're,
chat.
they're coming, yeah.
It's a bit of a public health construct,
Mhm.
but primary prevention is the.
Okay, so you have about 33% says discussing the importance of checkups, 34% providing HPV vaccines, and 31% screening and treating of abnormal cervical lesions. 2% referring to gynecologists.
Okay, great. And this is perhaps not such a fair question, but it's a public health construct. When we talk about kind of primary prevention, secondary prevention, I'm looking down at the bottom of the screen, and tertiary prevention. And those are the methods that will prevent the disease. Primary prevention is something that will prevent the disease from ever occurring, hopefully. And that's HPV vaccination programs. And in fact,
Get my bags, please. My bags.
In fact, cervical cancer is the only cancer that we now have a vaccine for. When this vaccine came out, it's got to be now about 15 years ago. It's pretty incredible that we can now vaccinate girls and boys, but mainly girls, for prevention of them ever getting cervical cancer. We're going to talk a little bit later about secondary prevention methods, and those are those screening methods that we'll talk a little bit about. And then tertiary prevention is once you've diagnosed cancer, can you treat it? Can you do surgical methods to treat the cancer itself and hopefully allow a woman to live longer? So that's treating of a diagnosis after it occurs, whereas secondary is screening and pre-cancer treatment. And this is, I'll touch on this a little bit later, but this goes a little bit towards HPV infections occur very commonly with women, girls in the ages of 15 and later. And then a lot of those HPV infections dwindle or don't progress at all. They go away, actually. The immune system in a healthy woman allows or causes those HPV, that human papillomavirus, to actually go away. Those that it persists and stays on, those then lead to some precancer lesions. And then if left alone without any treatment, they could indeed progress to cancer. But the progression is incredibly slow. That's a good thing about cervical cancer. here's another way of looking at it. So an initial HPV infection in a girl at sexual debut, for example, she may have an infection, but the vast majority of those are cleared. They clear that HPV within some months. Some of them persist and stay on. And then there's a span of perhaps 4 to 5 years of that persistent infection. And then it could develop to a cervical interepithelial neoplasm or a precancerous lesion. And that progression is incredibly long, drawn out, probably around 8 to 9 years. And then eventually, if left alone and not treated, it could lead to cancer. So this progression is very, very slow. That's one of the, I guess, probably the only good thing about cervical cancer. The progression is slow. And it depends on lots of different factors, but the vast majority of the HPV vaccine or HPV, human papillomavirus infections, are cleared by women, especially. Now that's different for a woman who has HIV. They're not cleared as well, but even a lot of those are also cleared. So many women who are exposed to HPV during their teens and 20s won't progress, won't develop cervical cancer. The vast majority won't. A lot of those infections get cleared. So several years ago, actually prior to May of 2018, many global leaders were getting together trying to think, what in the heck can we do about cervical cancer? And they called it, they present some white papers, and they had a call to action. And in November of 2020, during the pandemic, they got together virtually and they worked on strategies to accelerate the elimination of cancer. That led to the July of 2021, just last year, some newer recommendations similar to what was done before, but they've advanced and come through with some really, really great recommendations. So this is kind of their plan right here. It has to do with, the vision of a world without cervical cancer. The goal being 4 cases or less of cervical cancer per 100,000 women years. I'll show you some data in a little bit. And that means that the targets by 2030, pretty darn aggressive, but pretty doable also. By 2030, the hope is to have 90% of girls fully vaccinated with HPV vaccine by 15 years of age. The second strategy includes screening with an HPV test, and that's trying to get at least 70% of women getting at least one test between the ages of 35 and 45 of an HPV test, slightly different than the typical pap smear that we've been doing for years. And then the last strategy is 90% of women that are screen positive get treated for those precancerous lesions. And that's a pretty doable strategy if you have the systems in place, and they aren't that expensive, they aren't that costly, but that will lead to about 30% reduction in mortality with a part of the targets that the WHO has set. So this is looking at some variables from cervical cancer incidence in the world, and this is several years old, but you can see with the arrow there, the Caribbean, from countries in Puerto Rico, a US territory, to some smaller countries, and then Jamaica. There's a fairly wide range of variability of cervical cancer incidence. And this is about 30 per 100,000 in Jamaica. And you'll see some of the other countries here, some of the lower and middle income countries have very high rates. Bolivia, Guinea, Malawi have very high rates of cervical cancer. All diseases that can be prevented with good strategies. This is a screen looking at the proportion of women that have been screened for cervical cancer between the ages of 30 and 49. And this again is some older data. You can look at some of the countries here. So Bahamas, data from 2013, Belarus, St. Lucia. Happy Independence Day again, St. Lucia, but this is data from 2012. And then you'll see St. Kitts and Nevis, data, older data from 2008. So you can see some of the countries from the Caribbean that you guys are representing are here with some slightly older data. And this proportion of women screened is fairly high in a lot of the countries where you all are working. But remember that these are averages. So if you're screening in the clinic system where I used to work, we were pretty proud of the fact that we would screen about 70% of the women that came into us annually. But that doesn't really tell the whole story. That meant that the ones that we were seeing were getting screened. But there's lots and lots and lots of women who never came to us at all, who are on the fringes of getting care at all. And those are the ones that are really tough to reach. And that's part of the goal. The higher incidence of cervical cancer are women who've never gotten screened at all, who have maybe fears or distrust of the medical system, or don't want to know if they have a cancer. And so they never get screened, or they don't want to go in. So those are the women that are really tough to reach, indigenous women or immigrants. And I wish I could tell you why that scratches on my screen right now. Somehow I must have drawn the lines. So this is a different look at kind of a life course and public health approach. So it's looking at those things that we mentioned earlier, increased coverage of HPV vaccinations. And then you look down the list of the accelerators, things that can make that happen, having a sufficient and affordable supply of HPV vaccine. And from what I understand, that the HPV vaccine is pretty readily available in the places where you all are working. But just in making sure that the women get it, the adolescents, women get it. And then you want to be able to figure out some ways to track. And then the next strategy is increased coverage of screening and treatment for precancer lesions. And that may be a bit out of your rubric or the things that you do, but making sure that there's sufficient supply, and the newer technologies are so incredibly important. The HPV detection strategies and HPV screenings are much, much more valuable than pap smears that we used to do, or cytologies. And then the last accelerator is, making sure that you have good quality pathologists and surgery, radiotherapy for those women who are end up being test positive for cancer or precancer even. So these are the levels that kind of we know from 2020 where progress is occurring. 85 countries around the globe have HPV vaccine programs, and the coverage varies widely, but the majority are still below this target of 90%. Many countries have screening, but it's not all that well organized. And then this has to do with HPV screenings. And so there's lots of countries that need to ramp up. And then cancer treatment, those are tough, attainable goals. This is I'll jump through this. This is some of the newer guidance with lots and lots of different recommendations. And the current WHO recommendations for screening and treatment, and again, I'm going to touch on this in the second portion, has to do with HPV DNA-based tests. We taught a lot of colleagues around the globe over the last 10 years or so, visual inspection of the cervix with diluted acetic acid or diluted vinegar, and that worked really well. However, we now know that the HPV testing is much better and much more sensitive to detecting the high-risk HPV types that cause cancer. Then there's very, very inexpensive treatments for precancerous lesions for women who test positive for HPV types that are cancerous. And those two typical, very, very low cost, one is called thermal ablation. I'll touch on that a little bit later, and cryotherapy is another one. Excisional therapy also works pretty well, but it's a little more expensive. So again, the goal is to get towards HPV testing. This is the left-hand side is the strategy that we were using for many years, pap smears or cytology testing, and visual inspection with acetic acid. That's what VIA stands for. And you can do that with the naked eye. I know that some of our trainings happen in Guyana, several years ago, I think mainly with the OBGYN department there, but they work well. However, there's better testing, there's better ways to do things now. And then, you know, the HPV test has really, really great quality. It has a potential to improve the efficiency and coverage with much, much easier testing, including the ability to do self-collection. So there's lots of countries now that are using self-collection testing, and it avoids the need for women to come in. There's someone's, oh, I thought I heard a dog. Never mind. And then there's,
Amanda, can you please mute your mic?
and
I
then
have it.
there's
I got it.
the ability to scale up and meet the needs. So all of these are doable. So this is another little look at the differences. So if we prioritize with HPV testing, HPV DNA testing, if we prioritize the women between ages in 30-49, we'd be doing an incredibly great service to women to prevent cervical cancer. We don't need to worry much at all anymore about those women that are younger, because we know a lot of those, that persistent HPV virus will be cleared. But so you could have a strategy that targets women in that age range alone, and you'd be doing great. For those women that are HIV positive, however, the age range is slightly different, 25 to 49. And then the frequency for HPV testing, it does not need to be every year. For years and years and years, we told women, you need to come back for your annual checkup. You know, you need to come back for your annual pap smear. We now know with HPV testing, that's not necessary anymore. And it's actually kind of a waste of energy, a waste of a woman's time, but also, and I know that, you know, in the clinic system where I worked, where we started shifting, women would come in and they'd say, yeah, I want my pap smear. And I would say, well, you don't really need it anymore. We can, you know, repeat your pap smear in 3 years, because we now know this test is much more sensitive. And it's hard to talk a woman out of that, but that should be the goal, to help them get the good quality testing and not as frequent. But it takes the program to make that program effective. You have to have good screening coverage. You have to have the testing needs to be linked to treatment. You should be, again, I mentioned this earlier about the equity issues, you know, getting to the women that are really, really tough to reach, the poorest, the most vulnerable, the hardest to reach, and then trying to figure out ways, strategies to integrate, as well as, you know, make sure that your systems and data collection systems are up to snuff. This is just a quick look at some of the programs where we had some cervical cancer prevention programs. I think the only country that might be represented on the call tonight is Guyana. These are some of the.
Belize.
Oh, and Belize, that's right. Belize also, yep. We had a strong program in Belize for many years. I don't think we're doing much there now, but. And this kind of talks about the different types of technologies that several countries, none of the Caribbean countries are mentioned here, but this talks about visual inspection. So this is kind of like a check look of some of the countries where Jhpiego has been working. This is a pretty complicated slide, but it talks a little bit, and I'm focused mostly on the side on the right. So there's lots of different policy innovations. They're decentralizing and task sharing, you know, that we don't need to have obstetricians, gynecologists doing pap smears or doing treatment of precancerous lesions. Those can be done including self-testing for HPV or nurses being able to do, and nurse midwives being able to do thermal ablation. It's a very simple task, and you know, midwives do many, many, many more complicated things than thermal ablation. They deliver infants, and they suture up lacerations, and they deal with postpartum hemorrhage. So this has a lot to do with ministries and helping think through task shifting and task sharing, but there's lots of good strategies to help further along the reduction of cervical cancer in many countries. And then there's a lot of new product innovations, and those include this newer, not so new anymore, but HPV testing Thermoablation is a much simpler way for dealing with a precancerous lesion. And then advocacy, that's a huge component that really takes a lot of work at the regional as well as governmental or national levels, but also good community engagement and getting communities involved. This is just a quick look at the different vaccines from two different companies. This is the one that was first released in many, many countries, Glaxo's 16 and 18 HPV types. You know what, let's call up another poll right now. I'm gonna back up. So if whoever's pulling up the polling questions, could you bring up the second question? I've given away some of the answers, so, or better said, I've helpfully enforced some learning.
Some persons are saying that they can't see the question, so I'm just going to read it. Cervical cancer is primarily caused by A, birth control pills, B, chlamydia infection, 3, promiscuity, D, persistent human papilloma virus. So you can put your answers in the chat, or you can answer on the poll if you can. Come on, there are 600 of you on the call, so let's see some numbers. Marcia, can you keep track of the chat answers? Let us know what the prevailing answer is in the chat.
Oh. D, the D, most people have,
Okay.
but D, I think I only see one A.
Okay.
The
So-
others are D.
In the poll for question 2, we have 3% said B, chlamydia, 3% said C, promiscuity, but 94% said HPV. B.
Great. Great. Wonderful. That's the correct answer, though. So persistent HPV, I mentioned it. Oh, now I can see the percentages. Great.
Yeah.
So let's do the next question while we're here.
Okay, which one?
The question, I think we're now on question 3.
3? Okay. Okay, for question 3, I'm going to read it. Oh, hold on, I can't see it.
It's back up now, 3.
Okay, question 3. The progression to cervical cancer from a precancerous lesion is approximately A, 6 months, B, 2 years, C, 5 years, D, 10 years. The progression to cervical cancer from a precancerous lesion is approximately A, 6 months, B, 2 years, C, 5 years, D, 10 years.
Chat. In the chat, it's mostly D.
Let me just mute this person.
D. Yeah.
Okay, and
D, but mostly D.
on the poll, if I can,
2, 3 C's.
okay. Persons are still answering, but
Yeah.
on the poll, I have 13% at 6 months, 17% at 2 years, 17% at 5 years, and 50% at 10 years.
Wonderful. So the 50% that answered D, they're the ones that maybe were paying a little bit of attention, or maybe they caught my notion. So cervical cancer progression is very, very slow.
Yes.
It's very slow. That's a good thing about it. The other good thing about it is that we have a vaccine that can prevent it. So it's a slow progressing cancer. And we now know that from many, many years of study. So the beginning of the persistent HPV lesion to actual cervical cancer is probably about 10 years or so. So it's a slow progressing. So we have the opportunity to catch precancerous lesions and very early cancerous lesions way before they ever get to the point where you can't get them treated. So that's a huge advantage. And let's jump to, if you could jump to question 5.
Okay. Question 5 says, the main HPV type, oh, somebody's moving my screen, sorry. The main HPV types that lead to cervical cancer are HPV 16 and 18. There's over 100 HPV types, so we don't really know. HPV 31, 35, 52, and 56. HPV is not the cause of cervical cancer. So the answers are A, 16 and 18, B, over 100 HPV types, C, HPV 31, 35, 52, and 56, and D, HPV is not the cause of cervical cancer.
And this would be just fine if you don't know this, because I don't think I've mentioned it quite yet. But, and you maybe never even knew
Yes.
this or heard of this, but I wanted to throw a question, maybe to reiterate or emphasize the point when we give them up with the answer.
Right. Marcia, what you're saying in
Some
the chat?
A's, some A's, some C's. More A's, A's.
Okay, on the poll, 72% at A, 11% at B, 17% at C, and okay, nobody said D.
Let's hear it for the A's. So,
Yes.
so the main cervical cancer types, or the better said, the HPV types 16 and 18 are the main ones that cause cervical cancer. And it's not, there's a whole slew of HPV types out there, many, many types. Some of them lead to genital warts, but those aren't cancerous. And so that's why you hear different numbers, perhaps, if you've heard people talking about the different HPV types, but the oncologists, or the ones oncogenic HPV types, are 16 and 18. There's some also 45, but the vast majority of the cervical cancers come from HPV types, that's what the explanation for this bivalent or bivalent vaccine
Yeah.
that targets the 16 and 18. And then there's a quadrivalent one, which hits on some other types. It includes 16 and 18, but it also includes 6 and 11. And those are more in line with genital warts. And then there's the non-valent, or 9 different, which really there's probably not a great need for this in most countries or in any country, but when they develop it, they've had a great marketing campaign and they started selling it. And of course, it's sold. But if I'm not sure which which vaccines you all have in your various countries, but my guess is it's either the Glaxo SK or the Merck bivalent quadrivalent, and they become a lot less expensive than they were initially when they rolled out. And you prioritize women in their ages 9 to 25, I'm sorry, between 9 and 13, ideally before they become 15 years of age, but you can still vaccinate women after age 13, 14, 15, all the way into their early 20s. And it still has an incredible impact. So don't stop if you haven't vaccinated a woman or she comes in and she still wants a vaccination after age 15 or so. And it's basically 2 doses given at 0.1 or 0.0 and then 6 to 12 months later. So there's lots of challenges, including COVID, limited resources, equipment, supplies, testing demand, quality, but a lot of those challenges are being met pretty rapidly, including, and I know that PAHO has worked with several of the Caribbean countries, including many where you are, that have linked access to vaccines, access to training programs and treatment programs, and data collection systems. So there's lots and lots of renewed government commitments in coordination and partnerships with PAHO and other donors, or PAHO and donors, I should say. There's just some really, really fast and progressing things that are happening. So lots of successes. And this is, a great time to think and move forward and trying to, I'm highlighting bullet 3 there, to work with the stakeholders to try to reduce this terrible burden of cervical cancer. This is from, a speech several years ago, about cervical cancer is not a journey for one person, it's a journey for the family, for the society, for our country, and for the world. So there's several resources that are here. We'll leave these in this section, or we'll leave these, you will have access to these slides in a few days. But then there's a lot of resources that JPIGO has put together over time, and some of these are listed here. So on that portion of this, and I should make note that many of these slides came from one of my colleagues, Veronica Reis, who lives in Brazil, has done a lot of work with cervical cancer programs in and around the world, not only in the Caribbean and Central and South America. How's everybody doing? I can't see people's faces, but I'm guessing everybody is hopefully
good.
smiling.
We're good in the Bahamas.
All right. All right. Great to hear it. So I think I have 3 more polling questions. And I have a few more slides that we can go through fairly quickly, and then we'll leave some time for questions, I think. So if you need to stretch, stand up and stretch a little bit, wiggle your shoulders, move your arms. The second part, we're going to talk a little bit more about screening and treatment options. And I recognize that many of you are not doing this. Probably most of you are not doing much in the way of precancer lesion treatments, but again, it is potential for midwives in lots of countries to be doing this. So I'll touch a bit on the history of cervical cancer screening. If I were in front of you, I would ask you, who knows the origin of the pap smear? But I'll touch on that in a minute. I'm going to talk about target ages and the frequency of screening or frequency of HPV testing. That third bullet, the same. And then there's, as I said, there's self-collection. I'll show you one of the pictures that is used for training women or showing women how to self-collect their own HPV test, very similar to their own pap smear. And then how to communicate results and discussing management of some abnormals. So the pap smear, this is what my guess is many of you are quite familiar with. In the system where I worked for many years in the early 2000s, all the way up into 2008 or 9 or so, we were still using glass slides. We had a fixative. We'd use a brush and or a spatula to get some cells from the cervix. And then we spread them on a glass slide and send it to a pathologist. And we get the results back usually within about 10 days or so. On the right, you see what a pathologist would look at. They fix the slide with some dye, and then they look for abnormal cells. And I'm not a pathologist, so I'm not certain what those slides or what those cells are, but I can tell you that, I'm guessing you in the same way, I would get lots and lots of my pap smears back, and they would say, can't read, too much blood, infection is obscuring cervical cells, need to redo. And so pap smear has been an incredibly important tool for reducing cervical cancer burden for many, many, many years. But we now have some better tools and better ways. The pap smear was actually developed by, I think he was a Greek doctor named Papanikolaou. And in the 1920s, he developed a technique, learned how that was what was causing the abnormal cells would lead to cervical cancer. And then the tools were perfected in the late 1940s and have been used for many, many years since then, all over the world, including, I'm guessing, in your countries. This is a little different look. This is, so cytology refers to the study of cells, or, and we now, many of us are using a different type, rather than a smear on a glass slide, we're using a brush and a spatula to get some of the cells, and we put them in a solution, swish them around, and then they go off to a lab where they can centrifuge out the cells from blood, and even centrifuge out, or separate out, I should say, the infections, and then test for abnormal cells. And this is a similar type vial that's used for HPV testing. So it's the exact same procedure. It's just a different testing mechanism. And you can see here, the attempt is to get some cells from the cervix. On this down at the bottom, that's the cervix. I liken it to, when I'm talking to women about it, it's like a little small donut. And we try to get some of the cells at the opening. The fancy word for the opening to the uterus is the cervix. And you can, even use a cotton swab or a brush. Better to get a little bit with a brush to get a little more cells. So again, this is looking at that. This is looking at that same those same targets again. Vaccination strategies, 90% is the goal. Targets, screening, that's what we're referring to now. And again, we're leaning more towards effective and efficient screening, and not trying to get every woman every year anymore. And this shows very clearly the differences between the different techniques of testing. So down at the bottom is what we've been talking about, pap smears. The sensitivity is about 38 to 83, a huge range. And then the specificity is not so great, but better, within a pretty good range of 60 to 95%, but we're still losing a lot. So then you go back up to the top, and that's where we see really, really great sensitivity, because it's designed to detect those HPV types that are oncogenic, those ones that are going to lead to cancer. And then one of the companies is Gene Expert. It's a pretty small little box that you put the vials in, and it spins them out, and then it selects out those HPV types. So HPV DNA testing is the goal. And the specificity is great, the sensitivity is great. Visual inspection with acetic acid, that's what VIA stands for, is another way that we were doing. Is a pretty low cost. And if you see a lesion, what the acetic acid does is it breaks down cells that have, it breaks away the cytoplasm, and the cells that have more nucleic acid or are replicating more rapidly have more DNA, and they show up as kind of whitish. So it breaks down the cell wall, and it leaves kind of a white area. And if you see that, in lots of countries they do this, the nurse does it with a speculum. She spreads a little acetic acid on the cervix. It looks at it after a few minutes. If it looks abnormal, she does an ablation. And that technique is pretty darn good because it will catch lesions. However, it's not as sensitive nor as specific as HPV testing. So the target population is prioritizing women between ages of 30 and 49. If you've got HPV testing, you can do that. For women who are HIV positive, however, then you want to do them as initially, especially if antiretrovirals are hard to come by, but you want to do those women regardless of their age. And then the frequency is not anywhere near as frequent as we've been doing Pap screening. We're doing it annually in many places, and now we can reduce that to even up to every 5 years for women who are HIV negative and have HPV test negative. So the frequency is reduced, and the age for initiation for doing HPV testing can be reduced. The old strategies, this is from 2013, 2014, where we talked about the WHO had a big campaign to do visual inspection and treatment. But now again, emphasizing that HPV testing is a good, fantastic goal for countries to be reaching for. This just kind of points out that lots and lots of women have trouble getting to a health facility because of their unawareness or their lack of knowledge regarding cervical cancer. It may take them too much time, cost. They have children issues, child care issues. They don't want to have a speculum. They've heard about this thing called a speculum, and they just don't like the sounds of it. And so they don't want that. They may have had bad experience in a particular clinic setting, and so they weren't respected or they treated poorly, so they may never want to come back. So all of those issues. And then the clinic systems themselves have, having a speculum, having an autoclave to sterilize the equipment you need, having your systems, having your Pap smear, if you're doing Pap smears, having those tools available, sterile equipment, all those things that go into barriers for reducing cervical cancer. But again, pointing more towards the HPV testing. I think we did this slide earlier, so I'm going to pass over it. So these are the HPV types that are the oncogenic. So there's lots and lots, 200 or so HPV genotypes. But the main ones that cause cervical cancer are 16, 18, and occasionally 45. 16 and 18 account for 70%, and 16 is the most oncogenic. So those are the ones that the HPV testing. So there's lots of ways that we can do HPV testing now. And once you have the equipment, which is not all that expensive, it can be facility-based, it can be community-based, you can do a hybrid. You can do it by teaching women to do it themselves. They could come into your setting and they could go into a bathroom and do it themselves. They can be sent the kits, they can pick them up in local community settings and then bring them back. Lots and lots of ways to improve getting tests done by task shifting and thinking through different strategies. Here's kind of what it looks like when you have a system where you're training folks. This is the tool, the inserter. It looks a little bit like a cervical brush, but not quite. It's got these kind of wings on it. And then you teach a woman to insert it inside, trying to teach her to get as close to the cervix as possible. Down at the bottom, you can see. And then she takes the inserter out. It's either a brush or a cotton swab type thing, and swishes it around in the vial, and then sends it off. Those tests can be run. They don't need to be cold. You can use them or have them at room temperature, provided it's not too hot. They can be, the lab does not require refrigeration. You can run the tests as soon as possible. They can be preserved or held off for 2 to 3 weeks. So that it's not a storage capacity issue, nor a thermal regulated testing system. So again, these are the most common types, 16 and 18. So the test results that would come back from this particular gene expert testing equipment, you'd either have HPV 16, HPV 18 and 45, or you'd have some of the other types might be listed, or there'd be an invalid or an error test. and then you proceed depending on that. And this, I think, I remember talking to patients early on when I'd say, we have your results back. We would set up our appointments, and women would come back to review their results. And then I got to the point where I was calling patients, and I felt that was simpler. But as soon as I mentioned anything about the word if I'd say, you have a little bit of an abnormality, pre-cancer, the word cancer is tremendously terrifying to anyone. And so I try to think through strategies. So you need to think a little bit about how you express something abnormal to a woman. And I would go overboard trying to say, this is nothing to worry about. These can be treated very, very simply, easily. Cancer, cervical cancer, slowly progressing. We're glad we caught this so early. You don't have cancer. So there's lots of different ways that you can talk and figure out ways to communicate about the results. I'm guessing that many of you already do that in lots of ways to convey information to patients, but the word cancer is tremendously terrifying to lots and lots of people. Yeah, I think I'll go past this. So here's kind of the results and the next steps. We do not need to be screening women as frequently as we used to be. So these are some of the treatment modalities. I'll go through these fairly quickly because we're running short on time. These modalities, thermal ablation is incredibly low cost, low risk of any complications. The acceptability is very, very high. It lasts, you'll see the tool in a minute in another slide, but it's about a minute-long procedure. And the cervix, surprisingly, has very, very few nerve endings on the cervix itself. And so it can be done very simply in an outpatient setting. It can be done by a nurse, midwife, doctor, and you ablate the tissue. So you don't have any tissue that you send off. So that saves a step also. This is a WHO recommended. Then there's cryotherapy, which is pretty darn effective, costs a little bit more. It's also low risk. And so these are the kinds of things that might, at a country level or a advocacy level, might be thought through. I'm going to show you a couple. There's several, many algorithms for linking and talking about HPV DNA testing, what to do after it's positive or negative, how frequent to test. Visual inspection or visual assessment of the cervix for treatment is one of the next steps. I'm going to show a few slides of some cervices that have been treated with acetic acid. So you look at this, and if you weren't familiar, you'd say, wow, that doesn't look quite right. But actually, this is a normal cervix. This is the transformation zone, and it's a little bit brighter red because those cells are a little more active with a little acetic acid on them. But that's a normal cervix, so there's nothing that needed to be done with that. This, on the other hand, with acetic acid, you can see that the white portions are abnormal. That's where there's more nucleic or more DNA cell in the cells themselves because they're progressing a little bit more rapidly. And this is where a cervix that you could treat with cryotherapy or with a thermal ablation, which would be the preferred method. This, on the other hand, is a similar in terms of a precancerous lesion. This is not cancer. This is a precancerous lesion, but because of the size, it envelops the whole cervix or all the way out to the edges. So in this case, you would need to use a LEAP or a loop electrosurgical excision procedure. And that's a little more complicated. That requires a little more training. And this, I'm guessing some of you have seen this, but this is a cancerous lesion. This is cancer already. Hopefully none of you, or many of you, hopefully you haven't seen that very often. This is kind of I'm pointing up a few little pictures here. This is a cryotherapy machine. And one of the reasons it's a little more burdensome, a little more cumbersome is because and expensive is because it needs this tank that has the CO2 gas that causes the freezing. You don't have to press the or is it do it for you? It freezes this lesion on the left is a precancerous lesion, so you freeze it, and it requires about 11 to 13 minutes of kind of on and off freezing. But by freezing, it ablates all of that abnormal cells, and that treats that So there's no longer precancerous lesions. On the right hand is the thermal ablation system. And you can see that it can be handheld. Some of them have a little battery operated system. They're incredibly inexpensive, and you can ablate that lesion and destroy it before it ever progresses. LEAP is kind of what I mentioned. It's a loop, almost like a paper clip that's connected to electrocautery, and it cuts very fine cut through part of the cervix, removes the abnormal cells, and then treats the woman so she's no longer has a cancer progression. I'm going to pass on. I think we're towards the end here. Again, emphasizing the three main strategies for reducing cervical cancer burden: vaccination with HPV vaccine, targeting those women in those main age ranges of 35 to 45, especially in low resource settings where you have trouble getting to women at all. If you can get them to come in at least for one screening for HPV, and preferably, but even a pap smear, if you can get a woman who's never had one, that's the age range to target. And then the goal is to make sure that you're getting those cervical cancers identified early, and they can get to treatment with good referrals. And on that note, I guess we can pull up the last. I think there were 2 questions left. We pull those up, and then we've got a little bit of time, I think, for some other questions. I'm going to back up.
Question 4.
Yes, question 4.
Is everybody seeing the question? It says, what percentage of women will be infected with HPV? What percentage of women will be infected with HPV? And your choices: A, 10%, B, 30%, C, 50%, D, 80%. Put your answers in the chat if you cannot access the poll. Come on, there are over 650 persons, so let's get some answers.
Okay, sorry. Good afternoon, all. This is Dr. Medford. I joined a little late. We're starting the quiz from number 1.
We are on question 4. Just answer question 4 in the poll for us, please. Marcia, what are you saying in the chat?
Is these a few C's, mostly D's, 2 A's, and some C's.
Okay. On the poll, I have 20% at 10. 20% of the answers are saying 10%. 49% are saying 30%. 13% are saying 50. And 23 are saying 80%.
Right. So, and because so the answer is D, 80%.
Mm-hmm.
HPV is the most common sexually transmitted infection of all of them. And because I've been talking about the oncogenic types and that, this progression is slow, I can see where people weren't focusing on this question refers to all of the HPV infections out there, and there's lots and lots and lots of them. So most women, 80% of women, will likely be infected with an HPV.
Some type of HPV.
Exactly, with one of the types of HPV viruses in their lifetime. Now, of that 80% that get infected, the vast, vast, vast majority of them clear those infections. They go away. They get cleared by the immune system, like lots of other viruses. So the 80% will be infected, but the vast majority of them clear. And those that don't, they become persistent HPV types, and they can then progress to precancerous lesions. So the progression is an HPV type, particularly an oncogenic type that persists and then progresses. The persistent ones then progress to a precancer lesion, which is very treatable, and then progresses to cervical cancer. And that progression is slow. It's probably around 10 years, as I mentioned.
Right.
Okay, let's jump
Next
to
question.
6.
Okay, so question 6 says, WHO's main strategy for the elimination of cervical cancer are A, providing HPV vaccination to all girls by 15 years. B, screening with at least one HPV test between the ages of 35, and I don't see the 35 and something,
45.
45. Okay, I need to open up my screen, sorry. 35 and 45. And, okay, what's the next one? Okay, provide treatment for 90% of precancerous or invasive cancer, and then all of the above. So providing HPV vaccine for girls by 15 years, screening at least once between 35 and 45, providing 90% of precancerous or invasive cancer treatment, and all of the above. I see in
There's
the
lots
chat
of
we're having a
Ds.
lot of D's.
Lot of Ds, yeah.
Yes.
It helped that I had the answer up in front of
On the screen, yes.
yes. So the answer is D. I hope I made that one clear. That's great. The answer is
Right.
D, all of the above. Those are the main strategies the WHO is promoting, and I'm guessing a lot of your places where you guys are
Yes,
working,
and
those are, yep.
in
So
the
let's
poll,
do
some
that.
person said A as well, but D would include A. So it's all of the above.
Yeah, exactly. Any of
Right.
those strategies would be good, but all of them together are the main strategies, the 3 main ones. And then the last question, number 7.
Number 7 says, treatment modalities for precancer lesions include. Treatment modalities for precancer lesions include A, cryotherapy, B, thermal ablation, C, the LEAP, which is the loop electrosurgical excision procedure, D, hysterectomy, E, A, B, and C, and F, all of the above. A lot of options, a lot of options.
Lot of E's. Lot of E's. A, A's, B's. Mostly E's, so E's, a few F was a choice, I've seen F. E's. A few A's, a few B's, but mostly E's.
Right. So
Great.
Vaccine,
Mostly E's?
yes, so A, B, and
Great.
C, yes,
Yeah.
in the poll as well.
Great, great. That's correct. Those, the answer is E. Now, I threw hysterectomy in there as an option. It would be overkill for a woman who has a precancerous lesion to do a hysterectomy. Now, if she had other reasons to have a hysterectomy, maybe you could do a hysterectomy if she had large fibroids, for example. But there would be no reason to do a hysterectomy on a woman that has a precancerous lesion. And the modality that's being strongly promoted and encouraged, and it's fantastic for lots of low resource settings, and the trainability is easy. That's the thermal ablation. It's that we have a program for training, but there's lots of entities that have programs for good thermal ablation training. And it doesn't need to be done by a doctor. So, and on that note, let's, I think we have some time for some questions. Not quite sure how the best way to do it, but.
Okay, so I have,
Marcia?
yeah, I've
Go ahead.
taken note of the questions as they came along in the chat. So
Great.
one of the first question, how effective is the HPV vaccine in women over 35 years?
Very effective. So I'm sorry, the vaccine, I was thinking of HPV testing. So it's not as necessarily means that it's not effective. It means that it's probably not going to do much. So it wouldn't hurt to provide a woman with that vaccine, but it probably wouldn't do much because she's likely already had exposure to the HPV types that the vaccine would typically prevent. So there's not a lot to do for those women. The typical cutoff age for HPV vaccination is about 26 years of age.
Okay, next question.
I think maybe I should add, the only caveat I can see to something like that would be a woman who has not had sexual intercourse, earlier in her life, and is maybe beginning sexual intercourse at age 30 or so. Then she would be a prime candidate for HPV vaccine.
Okay. Next question. Is there an age limit for one to have the HPV vaccine?
Yeah, no, it's not an age limit. It's just, as I mentioned, it's, part of the reason also is the cervix, the transformation zone, and the cervix that are rapidly changing. That happens in a woman in her younger years. To the cells that are rapidly undergoing change and transformation, those are the ones that are susceptible to something that would trigger a beginning of an abnormality like cervical cancer. And as a woman ages, or not even ages, but as she gets into her mid-20s or late 20s, that endocervix is now becoming more keratinized to yeah.
Okay, next question. Should a woman with a family history of cervical cancer have a pap smear or HPV testing?
Interesting question. The short answer, I think, is no. And there are some cervical cancers that are probably hereditary, but the vast majority, it's one of the few cancers we actually know what the cause is, and it's an HPV vaccine. It's an HPV, human papillomavirus. So the short answer, I'm pretty darn sure, is no. Just because she has a familial family history of cervical cancer does not mean she's more susceptible to cervical cancer than anyone else. It's the HPV virus that would cause cervical cancer. So she should be vaccinated, of course, but you don't need to do any additional screening for her.
Okay. At what age, similar to before, at what age do you suggest we stop administering HPV vaccines?
Yeah, it's similar to the last one.
Yeah.
Yeah.
All right. And how?
I'm going to add another piece to that question about familial history, because a lot of times we hear women who come in and say, my mom died or my aunt died of X cancer, and sometimes they know exactly what cancer it was, and sometimes they don't know. So if they can pinpoint it, I know exactly it was uterine cancer, or I know exactly that it was ovarian cancer. That's very different than a woman that said, you know, I have my aunt died or my grandmother died of a cancer in her something down there, and they're not sure what it was. So if you know what type it is, that's really helpful, but many women aren't sure.
Another question, how serious can we take an inflamed cervix and one that is noted to bleed on contact?
Yeah, that's a good question. That's pretty darn common with an inflamed cervix. You touch it with a brush and it starts bleeding. And the short answer is you don't need to worry about it too much. There's perhaps as an inflammation is due to an infection, and therefore you could treat, you know, a broad spectrum antibiotic perhaps, where you could test and see if you can visualize what it is. You know, with a microscope, you could do a microscopic look at it, but just general inflammation that causes bleeding, unless it's a woman that's later and you think, oh my gosh, this doesn't look like just an inflamed, infected cervix. This looks like something worse, like a cancer or a precancer lesion.
Okay, and another question was, what is—
You know, I'm going to add another piece to that. You know, in this day and age, I'm guessing many of you have referral colleagues or your go-to person. You go, I don't know what to do with this particular thing. You know, and we now have the ability to take a picture of something and send it off to a colleague. If you can do it in a safe, confidential way, that's a great way to help get some collegial support, trying to figure out, what do I do with this particular lesion I'm seeing? You know, it's a great new age where we can do that much easier than we used to.
Okay. Another question was, should the HPV vaccine be given to the male?
To which
The
group?
male.
Males. Yeah,
Males.
many countries, yes, for sure. And many countries are expanding and including our own, because we know that the transmitter, or one of the transmitters, is men of the HPV virus. So yes, it's a bit tougher sell, and it's a bit tougher to promote that in many countries. So, you know, if you just targeted women or adolescent girls, be doing great. But if your program is now robust and you can move towards vaccinating boys as well, great.
Okay, another question. What is the safest mode of delivery for a woman with cervical cancer?
Meaning she's pregnant, has cervical cancer diagnosed.
Yeah.
Whoa.
Yeah, I guess.
Oh boy. That's a tricky one. I guess I'd probably work closely with an oncologist, and I'd probably talk to an oncologist. My guess is they would say, deliver the child via C-section and do a hysterectomy at the same time. I don't remember if I've ever encountered that, but yeah.
Okay. And there was a
And I
question.
should add also to that point, I didn't mention it earlier, but there's, you know, we sometimes shy away from doing a Pap smear on a woman who's pregnant, and you don't need to do that. You can do a Pap smear on a woman who's pregnant, and a woman can do self-testing, a self-collection of an HPV type test as well when she's pregnant.
Okay, there was a concern, a question about the adolescents who may not have received the HPV vaccine. Well, this person is asking, how often should a Pap smear be done once the child becomes sexually active?
The general trend now is at least wait till they're 21 years of age. We used to start doing Pap smears when women would say that they've started having sexual intercourse. We now know there's no need for that, especially, well, 21 years of age or older, especially if you've got HPV testing capabilities, because as we pointed out, many of those HPV types don't persist. They get cleared in a healthy younger woman. So we definitely don't need to be doing as many pap smears or as early pap smears as we used to.
Okay, and can persistent or recurrent cervical inflammation predispose one to cervical cancer?
Persistent,
Or
I missed the-
recurrent?
I'm sorry, can you say it one more time?
Can persistent or recurrent cervical inflammation predispose one to
Oh,
cervical cancer?
I don't think so. I guess the only thing I can think that might is a persistent infection or an inflammation. I don't think they're any more, no, the short answer is no, they're no more susceptible to cervical cancer than anyone else. I guess the only caveat I would say is if they're HIV positive, then they are definitely are more susceptible to persistent HPV virus and therefore persistent or a lesion that could become cancerous.
And is there any evidence that the use of condoms prevent the spread of cervical cancer?
Sure, because it would prevent the spread of HPV, but it wouldn't be, it would have to be ever, always. So, but yes, for sure, it will prevent the spread of HPV virus infections for sure.
Okay. And there was another concern about the adolescent and the vaccine disrupting their cycle, the menstrual cycle.
Huh. I've never heard that. I don't think that's the case. And I mean, I guess it's possible, but I don't think I've ever heard that the vaccine would disrupt a woman's cycle. And an adolescent, on the other hand, their cycles are irregular to begin with. So, but I doubt it has anything to do with the vaccine.
Okay.
You know, I'm hearing lots of questions about adolescent, which is fantastic. I'm glad you guys are seeing adolescents and thinking about care for adolescents because it's a tough group in many regards. But I think Ann pointed it out early on about thinking of strategies to, you know, encourage community engagement and encourage vaccination for HPV, and then somehow leaning towards, you know, different discussions of just general well-being and health for adolescents and safety precautions and drinking and driving and all kinds of things that I'm sure you guys do a lot of with adolescents, but contraception use if they become sexually active. And you know, when I was seeing adolescents on a frequent basis, the first thing I would do with them is I would say, thanks so much. I'm so glad you're here. Congratulations on being here at all, because just to get to a site is a big step for an adolescent. You know, they're nervous perhaps. And in my case, because I'm male, they're maybe even more nervous, but they're, you know, just that initial hoop to get them to a service provider or a clinic site or a community health center is huge. And so we should be congratulating them wherever they show up, whenever they show up.
Okay, so the last question, because there are so many, is high vaginal swabs necessary after a subtotal hysterectomy?
It depends a little bit about the definition, what people use as subtotal of hysterectomy. So if there's still a cervix after a woman has had a hysterectomy, if they've left the cervix behind, then yes, they're still susceptible to cervical cancer and they still would need screening. They probably don't need it, you know, all the way into their 80s, but you can, and especially if you're doing HPV testing. So they definitely would need, if they still have a cervix, they're still susceptible to a precancerous and then perhaps a cancerous lesion.
Okay, thank you very much, Mark.
Thank you very much. Those are tough to consolidate all those questions. Thank you much.
Yes, okay. Sonia?
Thank you very much for the question section, Marcia. And thank you so much, Dr. Hathaway, for your presentation. It was quite informative. I learned a lot, and I'm sure all of our guests right now had learned a lot. For those that were, because I saw in the chat, a lot of persons are requesting CME. Please note that you must fill out the Google form. It is in the chat. So you must fill that out so that we will be able to send you your certificate. Is there anything you would like to say, Dr. Shirley Curtis, before we go?
Yes, I just want to agree that it was a very informative presentation. I'm seeing in the chat person saying great
Excellent. Yeah.
presentation, informative presentation, excellent presentation. So we'd like to thank Dr. Mark Hathaway as well as Ann Pfizer for joining us and giving us food for thought and information by which to manage our patients. Even if we are not doing the pap smears, we are seeing the results and we are seeing the women. So we can encourage them to have their testings done, whether it's the HPV vaccine or having the swabs done, the cytologies, whatever is being offered in your country. We should see that our women are screened on a prescribed schedule. As Dr. Hathaway was saying to us that the annual, if you're doing your HPV and your screening, sorry, I just need to mute somebody. The annual pap smears might not be necessary. And so we need to become more informed. And if you can, please get your hand on the WHO recommendations of 2018 for the prevention of cervical cancer, to bring yourself up to date on what is current in the management and the prevention of cervical cancer. You got a lot of information, but there's a lot more. So you need to read that document and familiarize yourself with it, and then educate the women accordingly. So thank you very much. The form is in the chat. If anybody is not seeing it, initially I had put the wrong link in, but I corrected it. I put the right one. It should say Google form when you open it. Please, you must complete the form. I've been noticing that persons come into the chat, into the group, and they're coming in late and coming in asking for CMEs.
Mhm.
It's just unfortunate that in Zoom, we don't cut off at a particular point that says if you come in at a particular point, you're not eligible for your CME. But we would hope that you would use the honor system. And if you know you did not catch the presentation, because even now I'm admitting people
Yes.
into the chat,
Yeah.
but some of them are people who dropped off and came back. So we know we have internet issues in the Caribbean. So that's why we are not as stringent, but please use the honor system. If you know you did not attend at least 50% of the presentation, you should not be requesting CNEs. All right. We'll use the honor system on that one. Okay. But it's in the chat, and please check it out. Make sure that you can access it, because once the Zoom link is closed, you won't have access to it. So even if you have to copy it and paste it elsewhere, if you don't have time to do it now, I know some persons sometimes are listening at work. Some people may be listening and driving. No, don't try to answer on the move. So just copy it and paste it, okay? Dion, your hand is up. You have a question? You can unmute. Yes, Dion. Dion Flanders. No?
Yes, good evening. I was just saying I'm not seeing the link to fill out the form. Can you
It's in the
resend it,
chat.
please?
It's in the
In the
chat.
chat.
It's there about 3 or 4 times. I will put it back again. I will put it back again. Okay,
Thank you.
problem. Susan, is that the same problem or no?
Doctor.
It's there though. It was just enter.
Yeah, it
So
was
just
there.
look at
Enter
just look
again.
at the chat and you will see it.
Yeah.
Just scroll in the chat. It says Google form. And oh, wait, hold on. Let me just stop the recording.